Hello, my name is Brianna McQueen. I am a neonatologist. I will be talking today about the use of automated hematology analyzers in neonates. I have no disclosures to make. I have not received any financial compensation for this talk. In this talk, I will review 3 examples of technological advances in the complete blood count, or CBC, that can benefit neonatology. These include quantifying the leukocyte left shift by improvements in identifying and tabulating immature granulocytes, in judging the state of erythropoiesis by improvements in the reticulocyte parameters, and in judging the state of thrombopoiesis by improvements in quantifying the immature platelet fraction. The complete blood count is one of the most common laboratory tests ordered on neonates and young infants. Advances in technology have enabled considerable progress in clinical laboratory hematology analysis, leading to improved test reproducibility, reduced variation due to human judgment, saved technician time and resources, and in some instances, hastened turnaround time. Many of the significant advancements in clinical laboratory hematology analysis have been with improvements from manual to automated methods. This image depicts how an automated hematology analyzer is able to give us more information via laser flow cytometry. In an automated analyzer, the subpopulations are separated on the basis of cell complexity, or side scatter, and fluorescent signal. The sample is exposed to a fluorescent dye, which binds to intracellular nucleic acid. The fluorescent signal strength is proportional to individual cell nucleic acid content. To start, we'll talk about what's available with white blood cells in regards to leukocyte differentials. The neutrophil left shift is an expression used to indicate an abnormal increase in immature neutrophils in the circulation. It can be measured via an automatic or manual leukocyte differential count. The neutrophil left shift has been used for decades as a marker of infection. In adults, it has been shown that the automated differential is equivalent or better than a manual differential in screening for infection, but it is unknown if one method of quantifying the left shift in neonates is better. And previously, no reference ranges had been established for neonates for automated differential counts. The earliest morphologically recognizable neutrophils are the myeloblast, promyelocyte, and myelocyte. These cells mature into metamyelocytes, then bands, and finally into segmented neutrophils. The measurement of left shift via an automated differential is quantified by immature granulocytes. Automated differentials measure promyelocytes, myelocytes, and metamyelocytes in the circulation. The immature granulocyte percent, or Ig percent, indicates the younger fraction of neutrophils expressed as a percent of neutrophils. The absolute immature granulocyte count is an absolute number of immature neutrophils per microliter of blood. The measurement of left shift via a manual differential looks at the immature to total neutrophil ratio, or the I to T ratio, or the absolute band count. The I to T ratio is typically calculated as the percent of immature neutrophils, bands and metas, divided by the percent of segmented neutrophils plus bands plus metas. To calculate the absolute band count, the percentage of leukocytes identified as bands is multiplied by the total leukocyte count. This value is expressed as bands per microliter of blood. The Ig percent and absolute Ig count are somewhat analogous to, but technically distinct from, the I to T ratio and the absolute band count. The automated leukocyte differential cell count is a relatively new innovation in clinical laboratory hematology, where large numbers of leukocytes are categorized by flow cytometric techniques according to their size and cytoplasmic and nuclear characteristics. A manual differential count requires a hematology technologist to microscopically examine 100 leukocytes on a stained blood film and count each cell according to morphological characteristics. From the flow cytometry, a scattergram is created and the immature granulocytes are quantified. In this image, the x-axis represents side scatter and is a reflection of internal cell structure. The y-axis represents fluorescence and is a reflection of more nucleic acid present. The automated differential does not give you a band count and thus not an I to T ratio because it is not able to separate out the bands from the segmented neutrophils, or basophils for that matter. Automated differentials have the advantage that a blood smear is not needed and technician time is not required to perform a microscopic analysis, thereby conserving materials and reducing technician time. Enhanced performance of the automated differential over manual methods has been reported from adult populations on the basis of much larger sample of leukocytes enumerated, plus the removal of human error in discriminating among cell types. So what about the babies? In many clinical laboratories, automated differential counts have replaced manual counts, but it's not clear whether this is appropriate for CBCs of newborn infants. Another barrier to adopting automated leukocyte differentials in neonatology has been the lack of reference intervals for the Ig% and absolute Ig count. Previously, the usefulness of the Ig% and the absolute Ig count as biomarkers for infection have not been compared directly with the I to T ratio and the absolute band count in infected versus non-infected neonates. We performed a study in 2015 trying to clarify these questions. The objectives of our studies were as follows. First, to establish reference intervals for the Ig% and absolute Ig count from automated differential counts using a large sample size of non-infected neonates from birth to 90 days old. Second was to determine paired correlations between the Ig% from automated differentials and the I to T ratio from manual differentials, and also between the absolute Ig count and the absolute band count. And third, to compare the statistical performance for identifying infection by these four methods of quantifying the left shift, using CBCs from large numbers of infected versus non-infected neonates. We examined results from over 10,000 complete white blood cell counts between May of 2014 and September of 2015 from infants less than 90 days old who had both a manual and automated differential count. Records were excluded from the study if the Ig%, absolute Ig, I to T ratio, or absolute band count results were unavailable, or if the Ig% or absolute Ig count results were flagged by the analyzer as requiring confirmation. We documented whether or not each neonate was infected, and all CBCs with elevated Ig%, I to T ratio, or both were manually reviewed. Infection was defined as having a positive culture of a usually sterile body fluid, including blood, urine, or cerebrospinal fluid, or those with negative cultures but a diagnosis of clinical sepsis. Clinical sepsis was defined by antibiotic administration for greater than or equal to 5 days because of the diagnosis of pneumonia or clinical sepsis charted by the attending physician. We then developed reference intervals for I to T ratio, absolute band count, Ig%, and absolute Ig count from non-infected neonates. The 10,714 CBCs came from 5,281 individual neonates with an average of 2 CBCs per neonate. The great majority of samples, over 90%, were from neonates greater than or equal to 34 weeks gestation at the time of birth. About 6,400 CBCs came from infants without infection, and 4,200 were from infants with culture-proven or clinical sepsis. Of the original almost 12,000 CBCs, about 1,200 CBCs were flagged by the analyzer and excluded. Reference intervals were generated using the CBCs of neonates with no evidence of infection. Neutrophil concentrations are typically higher during the first 48 hours after birth. Therefore, the reference intervals generated were divided into 2 periods of time, the first 48 hours after birth and 48 hours through 90 days. The upper reference interval, shaded in red, for the I to T ratio was 0.29 in the first 48 hours and 0.31 thereafter. For the absolute band count was 3,710 per microliter of blood in the first 48 hours and 1,785 per microliter of blood thereafter. The Ig% was 6.2% in the first 48 hours and 4.2% thereafter. And the absolute Ig count was 1,460 per microliter of blood in the first 48 hours and then 613 per microliter of blood thereafter. These images show reference interval charts for the Ig% and absolute Ig count for the first week after birth. Mean values are in black, and the 5th and 95th percentiles are shown with the red dotted lines. This chart shows explanations for the 1500 CBCs where either the Ig% or the I to T ratio was elevated in a discrepant way versus both values were elevated. A repeat manual differential within 3 to 6 hours was reversed from the first. Thus, bands were likely initially reported as segs, and segs likely reported as bands. And the clinician noted in the record that the differential count was likely erroneous in 3 cases, shown in the farthest right column. There were 605 CBCs available from neonates with an elevated Ig% but normal I to T ratio. In these, 44% were diagnosed and treated for infection despite a normal I to T ratio. Conversely, 830 CBCs had a normal Ig% but an elevated I to T ratio, and 49% of these were diagnosed and treated for infection. Those with elevations in both the Ig% and I to T ratio had a higher likelihood of receiving treatment for infection. This graph shows the relationship between I to T ratios from manual differential counts and Ig% from automated differential counts, with paired results shown as individual dots. The R value is 0.18. The weak correlation between the I to T ratio and the Ig% is likely because they assess related but distinct developmentally different stages of neutrophils. The I to T ratio focuses on mature neutrophils, principally evaluating the proportion of bands to segmented neutrophils, while the Ig% focuses on yet less mature neutrophils, quantifying the proportion of granulocytes composed of promyelocytes, myelocytes, and metamyelocytes. The 4 methods of quantifying the left shift had similar statistical performance for suggesting the diagnosis of infection. For each of the 4, the sensitivity was weak, between 12 and 15%, while the specificity was strong, between 90 and 95%, and the positive predictive value and negative predictive value were typically in the low to mid-60s. Combinations of the 4 tended to diminish the sensitivity but increase the positive predictive value. Overall, statistical performances of the 4 methods were equivalent for identifying infection, but all were fairly poor. In conclusion, information from automated differentials is not inferior to that from manual differentials in identifying infection in neonates. Using an automated differential count would likely suffice for evaluating the left shift in neonates. Also, automated differentials have the advantage of larger sample size, being less expensive, and having faster performance times. Moving on to talking about red blood cells, we'll now discuss reticulocyte parameters in automated blood cell counts. Reticulocytes are immature, anucleate circulating red blood cells. They are called reticulocytes because of a reticular network of RNA visible microscopically when blood is stained with certain stains. The images here show the maturation of red blood cells starting with a proerythroblast on the far left, then a basophilic erythroblast, then a polychromatic erythroblast, next an orthochromatic erythroblast, then a reticulocyte designated by the black arrow, and finally a mature red blood cell farthest on the right. Reticulocytes circulate for about 1 day before they lose the RNA and organelles that give their rise to their reticular appearance, after which they continue to circulate for about 120 days as mature red blood cells in adults. This lifespan is generally shortened in neonates. Historically, reticulocyte counts were generated by manual methods, with technologists evaluating at least 100 red blood cells and reporting the percentage that stained as reticulocytes. Newer automated methods use standardized gating of cells based on size and RNA content. This image shows the reticulocyte channel produced by Sysmex analyzers. The x-axis represents side fluorescence, reflecting nucleic acid content, and the y-axis represents forward scatter, reflecting cell volume. The blue oval area represents mature red blood cells, and the orange-red areas represent reticulocytes. Quantifying the reticulocyte percent or count can be of value when evaluating the cause of anemia. Namely, a very high reticulocyte count suggests blood loss, as happens in hemorrhage or hemolysis, while a low reticulocyte count suggests that anemia is on the basis of red cell production failure. The absolute reticulocyte count is the number of reticulocytes per microliter of blood, reflecting the number of new red blood cells produced in about the previous 24 hours. We often discuss the reticulocyte percent in neonatology, but the absolute reticulocyte count may be of value as well. A case when this additional parameter could be useful would be in a very anemic patient. The reticulocyte percent changes when the hemoglobin or hematocrit change because it is a percent, and thus what might appear to be an elevated reticulocyte count in a very anemic patient could give a false impression that the marrow is responding well and that the anemia is due to blood loss or hemolysis. However, if the absolute reticulocyte count is very low, this would then indicate that red cell production is also inadequate, suggestive of a hypoproliferative or combined mechanism. The immature reticulocyte fraction is the proportion of reticulocytes with high RNA fraction, and is a ratio of immature reticulocytes to total reticulocytes. The immature reticulocyte fraction is an early and sensitive index of marrow erythropoietic activity by measuring the most immature reticulocytes in the circulation. Increased immature reticulocytes indicate acceleration of red blood cell production. The reticulocyte hemoglobin content, also available on reticulocyte parameters with automated analyzers, quantifies the amount of hemoglobin in reticulocytes, and thus provides information about the availability of iron for hemoglobin synthesis. The reticulocyte hemoglobin content provides information about the availability of iron for hemoglobin synthesis in the days immediately preceding the specimen collection. With limited iron stores, less iron is available to reticulocytes in the bone marrow for incorporation to hemoglobin. Thus, the reticulocyte hemoglobin is low. In older children and adults, the reticulocyte hemoglobin has been used as a means of assessing iron deficiency. The reticulocyte hemoglobin content has an advantage for use in neonatology. First, it is not affected by inflammation, as several other markers of iron sufficiency are. Also, it is obtained from certain hematology analyzers on a very small sample of blood, as low as 88 microliters of blood, as part of a CBC, and does not require additional phlebotomy. Limitations in using reticulocyte hemoglobin content for evaluation of iron status in neonates includes that we previously lacked reference intervals for neonates, and there have been no large studies in preterm neonates looking at the accuracy of the reticulocyte hemoglobin content in evaluating the iron status of neonates. Shown here are results from a study by Christensen et al. Published in 2016 that was performed to define reference intervals for reticulocyte parameters in neonates. The infants in this study were predominantly late preterm and term neonates and had never been transfused. These reference intervals were created from about 6,600 CBCs. The last topic that I will be discussing is thrombocytopenia in neonates and parameters available to assess this on automated differentials. Thrombocytopenia is a common problem in neonatal intensive care units. When a low platelet count is discovered, the etiology of the thrombocytopenia is not always clear. In general, thrombocytopenia can be due to two different mechanisms. The first is hypoproliferative, or decreased platelet production. Examples when this occurs are birth asphyxia, small for gestational age infants, trisomies 13, 18, and 21, and other specific syndromes. The other mechanism is consumptive, or accelerated platelet consumption. This can be immune-mediated due to infection, disseminated intravascular coagulation, or necrotizing enterocolitis. There are many other causes of thrombocytopenia not listed on this chart. The immature platelet fraction, abbreviated IPF, is a measurement of immature platelets in the circulation and is analogous to the reticulocyte count for red blood cells. The IPF is a reflection of the state of thrombopoiesis. The image here shows the fluorescent platelet channel from an automated hematology analyzer. The x-axis represents side fluorescence, reflecting nucleic acid content, and the y-axis represents forward scatter, reflecting cell volume. The light blue area represents platelets. Immature platelets have a larger volume and increased fluorescent intensity compared to mature platelets. The IPF is designated by the green oval within the light blue. The immature platelet fraction can be reported in two forms. The IPF percent reflects the percent of immature platelets, and the immature platelet count, or IPC, is the absolute number of immature platelets per microliter of blood. As is a common theme in this talk, these additional CBC parameters may be helpful in the workup of thrombocytopenia, but we don't know what normal values are in neonates. We did a study in 2016 to evaluate the immature platelet fraction in neonates. Our study had two objectives. The first was to create reference ranges for IPF parameters in neonates according to gestational age on the day of birth and postnatal age. The second objective was to evaluate if the IPF can be used to categorize neonatal thrombocytopenias based on their underlying kinetic mechanisms. For our database, we obtained CBC results from infants 0 to 90 days of age that had a platelet count and IPF parameters from May of 2014 to June of 2016. To create our reference intervals, we removed those CBCs from neonates with platelet counts less than 120,000, if they had a platelet transfusion in the previous 3 days, or both, leaving a group of CBCs without thrombocytopenia. We performed a retrospective analysis of de-identified data from non-thrombocytopenic neonates to create reference intervals for IPF percent and IPC according to gestational age at birth and postnatal age. For the second part of our study, we reviewed the charts of neonates who had 2 or more platelet counts less than 100,000. This review was performed by 2 independent reviewers. Each of the neonates reviewed were judged to have thrombocytopenia from a hyperproliferative cause, such as a syndrome, small for gestational age, or birth asphyxia, a consumptive cause, such as immune-mediated necrotizing enterocolitis, disseminated intravascular coagulation, or sepsis, elements of both, or an indeterminate cause. An example of when both could be contributing would be an infant who is small for gestational age and has immune-mediated thrombocytopenia. The mechanisms for each infant's thrombocytopenia were decided independently of the IPF. We started with over 24,000 CBC records from over 9,000 neonates with both platelet count and IPF values. 3,700 CBCs from about 1,000 neonates had platelet counts less than 120,000, had a platelet transfusion in the 3 days prior to the lab testing, or both, and were excluded from the reference range analysis. This left about 20,000 CBCs from 8,000 neonates without thrombocytopenia. Of the CBCs with platelet counts less than 120,000, 1,863 of these CBCs were from 280 neonates with at least 2 platelet counts less than 100,000. The graphs here display reference intervals for the IPF percent and IPC on the day of birth according to gestational age, with gestational age along the x-axis and IPF percent or IPC along the y-axis. For this and the next slide, the 5th percentile is represented by the lower blue dotted line, the 50th percentile represented by the smooth black line in the middle, and the 95th percentile represented by the higher red dotted line in both graphs. The upper reference intervals for IPF percent and IPC at birth decreased with increasing gestational age. The graphs here display reference intervals for IPF% and IPC during the first 90 days of life, with day of life along the x-axis and either the IPF% or IPC along the y-axis. For both measurements, there was an increase in the upper reference intervals over the first 2 weeks before leveling out and eventually starting to decline around 2.5 months of age. This chart shows the means and standard deviations of the IPF% and IPC from 280 neonates who had 2 or more platelet counts less than 100,000. 92 of the 280 babies had hypoproliferative thrombocytopenias, 98 had consumptive thrombocytopenias, 76 had elements of both, and 14 were indeterminate. When comparing just the hyperproliferative to consumptive, neonates with hypoproliferative thrombocytopenias had lower IPF% and IPC values than did neonates with consumptive thrombocytopenias, and this was significant with a p-value of less than 0.0001. In conclusion, neonatal reference intervals for the IPF can be used to recognize abnormal values. In thrombocytopenic neonates, high IPF values suggest consumptive varieties of thrombocytopenia, and normal or low values suggest hypoproliferative thrombocytopenias, thereby helping clinicians understand the etiology of the thrombocytopenia. So to wrap it all up, some closing thoughts. Automated methods may generate more reliable results than manual methods because they sample a much larger number of cells and omit errors from subjectivity among human observers. Reference intervals for these tests in newborns allow the new CBC parameters to provide quantification of a neonate's left shift, improved assessment of neonatal erythropoiesis and identification of iron deficiency, and assessment of the thrombopoietic state. Thank you for your time and attention.